Awesome. Well, thank you for having us. We're C Consulting. I'm Anthony. This is Emma, Estefania, and Saisindu. We can confidently say that everyone in this room has felt the pressures or heard of LA traffic. You leave 5 minutes late, hit one red light, and suddenly you're stuck. No control, no visibility, no idea how long it's going to take. Now imagine that same feeling, but instead of being late to work, you're trying to book a doctor's appointment, or you're in an ED wait room, or you've been discharged, but no one has come by with any answers. You're stuck in the system. That experience reflects a greater issue across all US healthcare, one that even leading systems like UCLA Health are trying to navigate today. How do we clear the congestion from care to entry to exit that works at scale?
As you all know, UCLA Health is a national leader in clinical excellence and innovation. This system cares for almost 900,000 people every year and has one of the most diverse and complex patient populations in the country. Today, UCLA Health manages over 5 million calls annually and has routine occupancy of over 100% across several of its systems. This puts pressure on the patient journey from scheduling to the patient experience in the ED to patient discharge. But it isn't a failure of clinical quality, it's a flow breakdown, and patients are the ones who feel it first. We sought to find the most effective and valuable uses of AI in mitigating this congestion. With the goals of remaining patient-centered, integrated, and intentional, we first provide an on-ramp to care with our AI-enabled call center. Next, your route to care, an AI kiosk triage. And finally, a clear navigation of care with SmartChart. These initiatives will expand access for patients, reduce wait times, and ensure a smoother caregiving journey for all.
As mentioned, UCLA Health handles a high volumes of calls coming in. To alleviate with over a 4% call abandonment rate. To alleviate this issue, we propose the On-Ramp to Care initiative, an AI-enabled call center using Elise AI. Elise AI is a conversational scheduling tool that works alongside FTEs and does not replace them. It uses natural, human-like language that completes full scheduling workflows, supports multiple languages, and integrates safely with Epic in a HIPAA-compliant way. For this assessment, we looked into the real estate industry, an industry that also manages high volumes of calls coming in. Using AI agents like Elise AI, renters saw an average response time of less than 60 seconds and a reduction in staff workload.
Taken together, these capabilities position Elise AI not as a standalone tool, but as a scalable infrastructure for access management. As the only HIPAA-compliant voice AI agent on the market, it enables UCLA Health to modernize front door operations in a way that is incremental, measurable, and aligned with long-term system goals. We start On-Ramp to Care with a 6-month pilot in primary care, where call volume is high and most requests are low complexity, making it the safest place to deploy Elise AI. We start by integrating the platform and gradually scale as we track for access, quality, and patient experience. At the end of 6 months, we make a data-driven, go-forward decision and scale by routing more calls to Elise AI, expanding across UCLA Health over 3 years, driving sustained access gains while optimizing talent without adding labor. Because of this pilot, we see break-even and gains in year 1. By year 3, we see over $15 million in annual net operating benefit as access recovery and call abandonment improvements ramp. At its core, this is an access investment, unlocking faster scheduling, recover lost demand, and higher value staff utilization.
We introduced On-Ramp to Care to help patients get their questions answered before they start their care journey. Now imagine you're a patient that directly comes to a UCLA ED, and now you need to find a way to navigate this traffic congestion at this critical point of entry. Your Route to Care initiative is our solution for this problem. Located within all UCLA Health EDs, it involves an AI kiosk triage process that allows you to choose your route to save faster care while also improving ED flow. The AI kiosk triage process captures symptoms and key details at arrival. Utilizing real-time triage intelligence, it stratifies patients by acuity level and recommends the most appropriate care pathway after clinician confirmation. This reduces ED bottlenecks and helps ensure that high-risk patients are prioritized sooner. Your Route to Care initiative looks like this. Say you arrive at the UCLA Santa Monica ED, you can either check in as usual or go to the AI kiosk triage. If you go to the kiosk, you complete a thorough symptom adaptive questionnaire that's then reviewed by a clinician to confirm your acuity. For patients with lower acuity needs, real wait times are displayed on your phone or iPad, allowing you to choose whether to remain in the ED or seek care at a different site. In the background, all this information flows seamlessly into Epic, supporting clinician oversight and improving ED flow. For this initiative, we were inspired by the aviation industry. Over 60% of travelers prefer using kiosks, and this has dramatically reduced wait times. This demonstrates that giving travelers the option of a self-service kiosk improves flow without adding staff or physical capacity. From the patient perspective, this is all about access and choice. The kiosk gives patients the option to avoid this congestion and reach their care site at an appropriate and fast manner, while always preserving the option to stay at the ED and receive care there if they want. Operationally, this is both a throughput and financial return investment. Higher acuity, high value patients can still be seen in the ED, while lower acuity patients remain within the UCLA Health System through urgent care. This increases bed turnover in the EDs and increases efficiency and capacity.
UCLA urgent cares are already utilizing predictive wait time technology. With multiple urgent cares being located near the Santa Monica ED, Santa Monica proves itself as a strong and practical pilot location for this. In the beginning, we're laying the foundation by integrating Epic with the kiosk, developing the model, and training necessary staff. So for the first 2 years, we'll be developing and in development stages. On year 3, we pilot the Your Route to Care initiative in the Santa Monica ED. And then on year 4 and 5, we'll scale this initiative across the organization in all UCLA Health EDs using the insights that we gained in the pilot. We're laying the foundation in year 1 and 2 by building the infrastructure, redesigning workflows, and validating the model. So we do see a temporary negative net benefit at first. But by year 3, we're essentially at break even as diversion and throughput improvements start to show up. In year 4, the program turns cash flow positive, generating about $4.8 million in annual net operating benefit a year, and then evening out to about $4.6 million after that.
We've shown how Your Route to Care helps patients avoid congestion and reach the right care setting. But once they're in the system, there's another kind of traffic we have to clear: the chart itself. Navigating a patient chart can feel like being stuck in traffic with no visibility as to what's actually causing the slowdown. Clear navigation of care is our response to that challenge, and SmartChart is a tool that makes it possible. UCLA Health already has a strong AI foundation in place through its multimodal embedding model for EHR, or MEME, which turns complex EHR data into clinician-style narrative summaries. This not only allows large language models to interpret patient information, but it also mitigates for black box concerns. The building blocks for clear navigation of care are already here. So if MEME is the engine behind clear navigation of care, SmartChart is what puts that intelligence into clinicians' hands. It brings together MEME summaries, operational data, and predictive risk signals into one conversational view. Instead of hunting through the chart, clinicians can ask natural language questions and receive real-time, decision-ready answers. And this isn't about replacing clinical judgment, it's about augmenting it. This is how clear navigation of care works in practice. A clinician can ask a simple question like, what's the delay in room 147's discharge? SmartChart returns a clear, real-time answer, separating clinical readiness from care coordination factors. This supports faster decisions, smoother discharge flow, and an overall clear navigation throughout the entire care process. SmartChart drives impact across multiple key areas. Operationally, it reduces length of stay and directly impacts system capacity. For providers, it allows them to practice at the top of their license by minimizing cognitive load and chart searching. And for patients, it provides a smoother journey for all, reducing delays and decision-making time. These improvements position SmartChart not only as a system performer, but also as a safety driver.
This idea is grounded in what we've seen already work for other high throughput industries. In retail, AI conversational tools have decreased and reduced resolution time by over 50% and have shifted staff efforts towards higher value care. Similar to the AI kiosk triage, the implementation timeline for SmartChart is also 5 years so that it can be safely scaled throughout all of UCLA Health. The first 2 years are all about creating SmartChart. So that involves AI development, EHR and Epic integration, and thorough staff training. Year 3 pilots SmartChart right here in Ronald Reagan in the West 6 of the MedSurg unit. Years 4 and 5 is scaling SmartChart throughout all of UCLA Health using lessons we learned from the pilot. As we mentioned, initially the first few years of SmartChart development is really creating SmartChart. So initially we see limited savings, but by year 3, this dramatically ramps up and we see about $6.3 million in savings and about negative $1.3 million in net negative impact. But once SmartChart is fully scaled throughout all of UCLA Health, we see about $17.1 million in annual net operating benefit. And once it's fully operational, we'll see recurring gains through reductions in avoidable utilizations and efficiency gains.
Now that we've shown the strategies and their impact, we shift to how we fuel these initiatives responsibly. After 5 years, these 3 initiatives produce over $37 million in annual net operating benefit, each targeting a different lever, including access recovery, ED capacity management, and length of stay reduction, creating both near-term and system-level value.
In designing this approach, we were deliberate about every detail, focusing on cybersecurity, environmental impact, change management, and overall experience. These strategies fit seamlessly into UCLA Health's existing operational workflows and security framework. Taken together, these initiatives are not only innovative, but responsible and ready to scale.
To measure success, we aligned our KPIs directly with the patient journey. For our on-ramp to care, we're focusing on call abandonment rates. Your route to care is about ED lobby wait times, and clear navigation is time to clinical decision support. We started with traffic, the feeling of being stuck, with no clear path forward. Using our initiatives of on-ramp to care, your route to care, and clear navigation to care is how UCLA Health gets unstuck, not by adding more lanes, but by making the system smarter. Thank you for your time. We're open to questions.
All right, I'll start. Great job, really good ideas. I like the traffic, metaphorically clearing the lanes, that was good. A lot of changes in call center and ER that will affect a lot of different people. You kind of briefly mentioned at the end, change management. Talk a little bit more about how you would roll this out across the system, knowing it's going to touch thousands and thousands of people and change their daily work.
Thank you so much for your question. So we know that Dr. Lukac here is the co-chair of the AI Council, so that team would be leading these projects. Additionally, we have accounted for the vendor, Elise AI, for the call center and what they would be held responsible for. Most of it is under Elise AI, as they have implemented this technology across other healthcare systems in the United States and already work by integrating into Epic. So other than that, we have the teams here at UCLA that are necessary to roll these out, and we have outlined what teams would be necessary. So for example, compliance and legal would be in charge of that contracting and that governance alignment that UCLA Health has stressed in their AI goals. Overall, this does touch a lot of people. So we want to ensure that we're not only looping in the AI Council and the vendor, but taking alongside leadership and our frontline workers throughout the development phases of these initiatives.
Thank you all. This is really great. I'm thinking about the kiosk in the ED and thinking about the demographic of patients that come into the ED, many of whom are traumas, many of whom are incapacitated, many of whom are not, don't have the ability to fill out a kiosk at any point. And oftentimes they're coming in solo. How do we think about patients that can't fill out the kiosk? And is there an expectation that it's only a certain percentage of folks that can fill out the kiosk? Is that the percentage that's going to help reduce your traffic, or is there a hope and expectation that it's 100%?
Excellent question. We realize that a lot of the people coming into the ED are going to be incapacitated or going to be in a vulnerable state. The kiosk is always going to be optional. Patients never have to go to the kiosk. The receptionist and the front desk staff will always be there to welcome and support those patients in need. That said, we know from the aviation industry that 60% of patients or 60% of travelers prefer the kiosk. So this kiosk is really intended for those lower acuity patients who can get care in other state or other contexts or other locations that might be more appropriate for them. So we fully expect that not 100% of ED patients will be utilizing these kiosks, and that is factored into our strategy.
I have a question. So for Smart Chart, in theory, that is something that we all expect that Epic will eventually do, in theory. And so I'm wondering, are you making an argument for us to build that internally? And what is that argument for doing so?
Yeah, great question. Thank you so much. So as we know, Stanford actually has already done like this homegrown version of Smart Chart through its chat EHR. And Epic is in the piloting phases of something similar like this at their other locations. Across the United States with other systems. What makes Smart Chart unique is UCLA's existing AI capabilities. UCLA is unique in the fact that it has the multimodal embedding model for EHR, MEME. MEME allows for large language models to interpret patient information rather than trying to make the EHR and that fragmented data be readable to large language models that cannot do that. Additionally, with what is existing at UCLA Health, that mitigates for black box concerns that haven't fully been accounted for by Epic. And this allows UCLA to be an example and at the forefront of innovation while still having that unique touch that gives you an edge.
Thank you.
Thank you, everyone. Great job. Similar to Julia, I'm thinking about the patient kiosk again, and I wanted to know if you have any information around how long it will take a patient to navigate through the kiosk, and if you have any data around adoption from a patient experience perspective on satisfaction rates.
Thank you so much for your question. That was a great question. So for the AI kiosk triage, this is a pretty quick process, and this is a simulation that will kind of show you how it would potentially work. So for patients, once they check in and they put in their key details, so their insurance card, driver's license, to really capture those details really fast, especially in those kind of patient cases where they might not be able to correctly input everything. This will quickly get through that process. And then with the symptom questionnaire, even though that's thorough, that'll quickly get done. And then that will generate an acuity level that will get checked by the clinician first. And then that will either go to the patient's phone because they put in the phone number if they have one, or they can grab a iPad that will be in the ED and they can get all this information there. So once the clinician approves this, they'll get the acuity level that will kind of match up with these urgent care locations to kind of predict these wait times. And UCLA already has urgent care times kind of built into their system. So this really integrates it into the kiosk and brings this into the EHR and really integrates it into the EHR so that if they do end up going to the ED, then all that triaging is already done. This saves a lot of time for the patients on their end and travel in terms of waiting, and also saves a lot of time for the clinicians that are taking these initial notes. And to kind of add on to that, kiosks have been used throughout all over the nations for different purposes. I specifically want to point out Cleveland Clinic. They have kiosks and their centralized patient check-in for all of their locations, and they have been received very well. So for lower acuity patients coming in, We know that this will be received very well if they're able to put in all that information, and people will always be there to help you, and you can always go to the front desk if you need additional help.
Hey guys, nice presentation. I like the transportation metaphor, and Anthony, your term congestion of care is great. I haven't heard that one before. Having had a cold during the holidays, I can empathize with that. Can you show me the rollout plan again? I think it was a 5-year plan.
Is there a specific, is it AI kiosk or smart chart that you're thinking?
Let's go with the kiosk. Yeah, there we go.
Oh, there it is.
Yeah. So just developing the model and training it, I see it takes 2 years. We have a pilot in year 3. Do you see an opportunity to create a minimum viable product with a shorter time frame where maybe we can iterate over time? So we'd get an MVP out in year 1, improve on that for year 2 and beyond. If so, what would that MVP product look like, where maybe you'd shave off some of the features and get something that can be deployed quickly?
That was a great question. Thank you. So this is our really suggested timeline, kind of looking at other industries and also looking at other AI tools that have been similar to this. So with this, because we are developing this internally, we suggest about 2 years for training and creation of it, but this can be adjusted based on what kind of features UCLA wants. We specifically have the pilot being about a year at Santa Monica, especially it being near all these urgent care sites for you to get the full impact. But this pilot can definitely demonstrate changes that need to be made. So all the internal teams, the AI council, all the frontline staff, they will actively be engaged in all the changes and be able to put in some of the inputs and suggest some features so that this can really be catered to UCLA and maybe even potentially be rolled out to other settings within UCLA where these kind of kiosks and triage systems would really create a system-wide impact.
Great. Thank you.